Thank you very much for that kind introduction, and thank you to the organizers for the invitation. And it's an honor to follow these two very excellent presentations that I think are incredibly important to the clinical practice of medicine. So we're moving from the true clinical practice to what I call hypotheses and speculation, but that I hope eventually will be clinical practice. These are my disclosures. And I want to begin very simply talking about what cancer is and how it relates to mutations. And from there we'll go to novel clinical applications that I think will be high impact in the future. So what is cancer and what causes cancer? And what do we understand about cancer so far? We have hypotheses or strong evidence that infections, DNA damaging agents, family history, bad luck or randomness, and time can all contribute to cancer. But in the end, they're all triggering mutations in a group of cells that result in uncontrolled selective growth. And these mutations, over time, we understand, can take a tumor or a cell from normal, and this is colon cancer, normal colonic epithelium, into a pre-malignant adenoma, into an invasive carcinoma, and finally into a metastatic tumor. And this is dictated by a couple of things. One is time. And in every cell, as we turn over those cells, you accumulate mutations. But if you accumulate them sequentially in cells that have these mutations that accumulate over time, you not only initiate cancer development, but you cause cancer progression. And to date, we have continued to evolve the understanding of cancer by doing the simple thing that we know how to do best, which is accumulate a lot of data. So we've sequenced virtually every tumor type out there. And what do I mean by sequenced? Currently, we're sequencing the coding regions of the genomes of these different tumor types by looking at the tumor and the matched normal from the same patient and identifying what's called somatic mutations, mutations just in the tumor of these different tumor types. And what we found is that there is quite a bit of variation between different tumor types. All the way on the right in the blue are pediatric tumors. Right next to them in the green are liquid tumors, low amounts of mutations. The garden variety tumors like colon cancer, breast cancer, pancreatic cancer have an intermediate range of mutations, anywhere between 50 and 100 mutations. Tumors associated with mutagens, things like smoking or UV radiation, have in the hundreds of mutations. And then tumors associated with things like mismatch repair deficiency, where you can't correct your genome, result in hundreds to thousands of mutations. So those studies have given us an impression of what the heterogeneity and the variation in total mutation number per tumors can be. But most recently, if you look at what's been cataloged, and there is a catalog called Cosmic, where I went into last September, there was almost 2 million mutations that have been identified in about 20,000 genes. And what's clinically meaningful to this? And if you look at it from the perspective of a medical oncologist, about 91 of those are meaningful. A handful, maybe a dozen, are associated with FDA-approved therapies, or therapies that we can immediately take off the shelf and treat our patients with. The remainder are associated with a prognostic marker or identify a patient that may be a candidate for a clinical trial. So of these almost 2 million mutations, just a handful in a few genes have immediate clinical impact. And pre-2006, what we understood about colon cancer was that it was just a handful of genes that caused the progression, and this happened over time. Now what we understand, because of the sequencing studies, is that the type of alterations are primarily what we call point mutations, or single base pair substitutions, here in the blue. And the other type of alterations, like deletions or insertions, amplifications, or translocations, are quite rare in colon cancer. And these are mutations that are well known to many of us. A lot of them we use in our clinical practice, but many we don't. And there are things like amplifications, just like in breast cancer and colon cancer, and ERB2. Actually, let me go back one. And then there are mutations in colon cancer, like BRAF, that are currently being targeted, and even rare mutations in genes called like IDH, which are being targeted in other tumor types. So there's heterogeneity in small populations, even in colon cancer. Just like lung cancer, we just need therapies to target them. And then if you look at the spectrum of mutations in colon cancer and compare it to the other solid tumors, it's very similar. So there's not a lot of dissimilarity between these different tumor types in terms of how they look from a mutational status. But there's one thing that I think is very important to point out, because much of this genomic information has been focused on finding drugs that target individual mutations, that are activating mutations, that are turned on. The major problem is there's just not that many activating mutations in the colon cancer. The majority of tumors with colon cancer do not have a single activating mutation. And you see here in the column on 0, it's about 45%. There are other activating mutations in genes like KRAS or PI3 kinase or BRAF, but again, these are rare. And it's a rare tumor that has multiple targets that can be drugged with an activating inhibition. What's more predominant are what's called tumor suppressors. So genes that are turned off by mutations. These are like APC and P53. So rather than being turned on and having the ability to turn them off with a drug, these genes are turned off. So it presents a issue that going forward from drug development is quite challenging. There's not many activating oncogenes, but there's a lot of inactivating tumor suppressors. And if you compare this to other solid tumors, it's a similar sort of picture. And it presents an issue. There's a lack of oncogenes. There's a lack of therapeutic targets. Few activating mutations in colon cancer. The tumor suppressors dominate. We have to learn how to target these. The best example that I've seen has been with BRCA or PALB2 mutations with alkylating agents, or more recently with PARP inhibitors. We have to start thinking that way with the genetics that's taught us in colon cancer. The other issue is heterogeneity. And there's a variety of different types of heterogeneity. There's heterogeneity within the tumor. There's heterogeneity between the same tumor but in different patients. There's heterogeneity between the primary tumor and the metastasis. And there's even heterogeneity between two different metastases. And the challenge here is this heterogeneity is triggered by two things: selective pressure and random mutagenesis. And when you apply a therapy, that allows the tumor to become resistant and to escape from that primary response that was present. So just to summarize where we were and where I was when I began a lot of these alternative uses of these mutations was that we understood that there was a variety of different numbers of mutations across tumor type, and it largely depended on etiology. The point mutations were the most common form of genomic alterations in colon cancer. The majority of alterations were loss of function, so they are very challenging to drug. And tumors were heterogeneous across not only the tumor itself, but across metastases. So even if you targeted one tumor, escape by any of the other metastases or the heterogeneity would be relatively easy for a tumor. So are there other ways to use this somatic information? And what I just described to you was using them as predictive markers. Could a single mutation, for instance, in BRAF, be drugged with a BRAF inhibitor, and could that lead to a response? So that's as a predictive marker. Or a prognostic marker. There are, for instance, BRAF mutations in colon cancer, a worse prognostic marker. But were there other approaches? And what I'm going to describe today are using them as either dynamic biomarkers, and I'll speak briefly on that, and then I'm going to speak more extensively on using these as immune antigens. Could these mutations be converted not into a specific target, but rather as in a way to stimulate the immune system and elicit a very potent clinical response? So I'm going to begin by discussing these as dynamic biomarkers. And this is work that we started about 10 years ago, but that had been ongoing for decades, really, primarily in the fetal maternal medicine area. And to understand what we're doing, we have to understand how do we test for mutations. Typically, we look at tissue, either frozen or formalin-fixed tissue, and we sequence that tissue, and in general, we just look at the tumor tissue or compare that to normal match from that patient. More recently, what has been a popular concept is using blood or plasma as a liquid biopsy to look for either circulating tumor cells or cell-free DNA. And when we think of a liquid biopsy, there's really two components. There is the plasma component, and there's a cellular component. What I'm going to focus on briefly is looking at the plasma component, which contains small fragments of DNA that are called cell-free DNA that are emitted by many different cells in the body. And the hypothesis is that these fragments are either secreted by cells in things like called exosomes, they are released into the circulation during apoptosis, or during necrosis, you have release of these large fragments of DNA into the circulation. So at first they enter the fluid around the tumor, and then they enter either the lymph or the blood circulation. And if you look at this pool of cell-free DNA in everyone's plasma, everyone sitting here, the majority comes from the bone marrow that's undergoing constant apoptosis and turnover. A fraction is coming from the GI tract, and a fraction is coming from the cell or the skin. These are all cells that are constantly turning over. If you have a pregnant female, a fraction of that cell-free DNA comes from the fetus. And that's a whole other field that's been exploding of looking at fetal genetics by drawing blood from the female, the pregnant mother. And you can detail very specific genetics in that in the fetus. If you have a transplanted organ, you can look at the circulating DNA and tell quite a bit about that transplanted organ, in addition to when it may or may not be rejected. And if you have cancer, a fraction of that DNA in the circulation comes from that tumor. And I'm not going to spend too much time right now speaking about all these applications. There's a session tomorrow where we're going to focus on this. But I'm going to briefly talk about some additional aspects that I think that will paint the picture of what this can be used for. One of the most potent reasons why using cell-free DNA is a great biomarker is that these mutations are present only in precancerous tissue or in cancerous tissue and not normal. So it sets up the arena for a perfect specificity. Now, that's a theoretical or biologic perfect specificity, but that as a starting point is much better than something like CEA, which is secreted by normal cells as well. You should not find a mutation in a normal cell. So it allows us to have a very specific biomarker. And in some of the early work, was led by Frank Deal, along with myself, looking at molecular analyses of cell-free DNA. The concept was the following. You took a patient who had a resected tumor, sequenced that tumor for known mutations. Since this was colon cancer, we knew to look for APC, KRAS, BRAF, PI3 kinase, identify the exact mutation, and then probe the plasma, the cell-free DNA, for mutations from that tumor. And using a technique called beaming, this was able to do a number of things all at once. And I can point your attention to the day zero plot all the way on the left, or right here. You can see in the green, in the upper left-hand quadrant, that's wild-type DNA, normal DNA from the GI tract, from the bone marrow, from the skin cells. And in the red, in the bottom right-hand quadrant, are the mutated fragments of DNA. This patient had metastatic disease, but it was potentially curable metastatic colorectal cancer that was undergoing a resection. The patient had it resected, and one day after surgery, virtually all of the cell-free DNA that was mutated disappeared. You can see there that the green fraction remains, which is the normal DNA, unmutated DNA, wild-type DNA, and in the bottom right-hand corner, almost all the red, or the mutated DNA, disappears. That's because circulating tumor DNA has a very short half-life, about 2 hours. So one day after surgery, virtually all of it's gone. At day 42, we got a scan. He was going back to see the medical oncologist, and there was no cell-free DNA, or there was no evidence of tumor on the scan. Now, this was an R0 resection. The patient was doing fantastic. But we started to get a hint that there might be an increase, or there might be tumor remaining, because there was an increase in the circulating tumor DNA proportion. Finally, at day 244, the CT scan was positive, and the circulating tumor DNA levels increased significantly. Now, this taught us a number of things, and this is one of the earliest studies. Number one, you could draw blood and genotype the patient, that the mutation in the blood would match the mutation that was in the tumor. Number two, that the levels correlated with the burden in a gross fashion in the patient's body. So before the surgery, he had bulky metastatic disease in his liver and in his colon. Once you resected that completely, you saw the levels go down. And then you saw the levels go up when there was a radiographic recurrence and even beforehand. But then it taught us a third thing that I think is very exciting. It allowed us to see subclinical disease. And it allowed us to see disease that the surgeon thought he'd gotten all of, and that the CT scan didn't capture, and that was not captured by how the patient was feeling, and was not captured, and I didn't show it here, by CEA. So it was able to determine and identify subclinical disease. And so we think that that's not only important for looking at what we consider minimal residual disease, but it could also be important for early detection in the future. And so, to summarize, the uses of mutations as dynamic or soluble biomarkers, they can be effective biomarkers largely because they're specific. Unlike things like PSA or CEA or CA125 or CA19-9 that are non-specific, that are secreted by normal cells, these are only secreted by tumor cells in the large quantities. I didn't go into this either, but digital genomics, next-generation sequencing, is really allowing us to bring this to the forefront and decreasing costs and increasing throughput. And applications not only will be genotyping and monitoring tumor burden, but we can also track the evolution of resistance and potentially look at minimal residual disease and early detection. And so there's a session tomorrow at ESMO where we'll go into greater detail about this technology. But the other approach that I want to spend the last part, or the majority of this talk on, is can we use somatic mutations as immunogens? Can mutations that are only present in the tumor stimulate the immune response, and can we somehow exploit that to garner a positive clinical response using some of these newer agents that augment the immune system? And so we've all heard and probably been jealous of the responses that our colleagues have had who treat melanoma, lung cancer, kidney cancer, more recently certain bladder cancers and lymphomas with checkpoint inhibitors, molecules that turn on the immune system, turn on cytotoxic T cells to eradicate tumors. And here's an example of a patient before and after treatment with a checkpoint inhibitor targeting at PD-1. And so we had a hypothesis a number of years ago, because when we saw that melanomas were responding, when we saw lung cancers were responding, we knew one thing from our early surveys and exome studies in patients, that melanomas and lung cancers had hundreds of mutations compared to all the other tumor types that weren't responding. And would a tumor that had not hundreds but thousands of mutations respond even better? So we hypothesized that tumors with mismatch repair that have hundreds to thousands of mutations would not only be more immunogenic, but would respond to checkpoint inhibition very potently. And so we went forward in looking at this, and I'll give a little bit of background, although the speaker earlier today did a fantastic job and I learned quite a bit. But microsatellite instability is due to deficiency in mismatch repair. I don't have to go into this because you had an outstanding lecture on germline and epigenetic silencing that can trigger mismatch repair defects. And what this does is result in uncontrolled accumulation of mutations as those cells continue to divide. And here's an example. And this is a different way of showing what I showed earlier. Liquid tumors, leukemias, have relatively low mutations on the very top. Pediatric tumors have relatively low mutations. Sporadic adult tumors have low mutations. But melanoma and lung cancer have many more. And these are the tumors that have been doing quite well with the checkpoint inhibition. But mismatch repair tumors, as compared to mismatch repair proficient colon cancers, have hundreds of thousands of mutations. And the thinking was, could each of these mutations in the DNA be transcribed into mutated RNA and then be translated into mutated proteins? And could that be presented to the immune system as something foreign? And if you had just a few mutations, the chances of that are low. But if you had thousands of mutations, you increase the chances. And that was the genesis of that hypothesis. So what we know about mismatch repair is that it's not only isolated to colon cancer, or HMPCC, but it's also found in other tumor types. We know that if you look at colon cancer in the whole, we say mismatch repair deficiency, or MSI, is found in about 15% of colon cancers, but in stage 4, or advanced colon cancer, that number goes down to about 3 to 5%. There's also a paradox, and this is something that we explored very carefully. In early stage colorectal cancer with mismatch repair deficiency, the prognosis is better. And point number one. Point number two, it appears, but it hasn't been definitively shown, that the response to chemotherapy is attenuated in these tumor types. However, when you look at mismatch repair deficient, or MSI, advanced tumors, the prognosis is actually worse. And so it's a paradox, and that's something that we observed from many studies that we compiled. But nonetheless, we wanted to target this subpopulation with MSI with a checkpoint inhibitor. And to tell you a little bit about the checkpoint inhibition pathway, PD-1 and Pembro, it's an antibody that blocks interaction between PD-1 and PD-L1, the ligand, and that disruption of that interaction allows for stimulation and activation of T cells, and in the hopes of triggering an anti-tumor immune response. Now, what does this pathway do normally? Well, it shuts down over or hyperactive immune responses. So in patients who have a strong infection, the PD-1 pathway turns on. So in cancer, you might have a tumor that might be triggering a very strong immune response, but then PD-1 expression and PD-1 pathway gets turned on in that tumor to suppress the immune response that might have eradicated that tumor. So we proposed the following study design. We looked at colorectal cancers that were mismatch repair deficient, or MSI, or mismatch repair proficient, or MSS. And we also included a cohort of patients that didn't have colon cancer, but were also positive for mismatch repair deficiency and MSI within the tumor. And were treated with anti-PD-1, in this case Pembro, at 10 milligrams per kilogram every 2 weeks. And the primary endpoint at 20 weeks was a combined endpoint of progression-free survival and response rate. And we tested for mismatch repair, or MSI, using the PCR-based assay. And this is the initial study, and the results were so promising that we met our early completion or criteria statistically. So we were able to stop the study early and present it, but we've continued to accrue, and we've accrued 25 in the colon cancer group at this point, a full 25 in the MMR proficient group, and a full 25 in the other non-colon cancer proficient group. But you can see here that the majority of patients were Lynch syndrome in the colon cancer group, and the patients with non-colon cancer MSI, about half of them were Lynch syndrome. And this is the earliest signs that we saw that we were probably having success with this approach. In the red are patients with mismatch repair deficiency. In the green are patients with colon cancer. In the red are patients with mismatch repair proficient colon cancer. In the green are patients with mismatch repair deficient cancer. And in the black are patients with non-colorectal cancer mismatch repair deficiency. Immediately for many of these patients, because they were treatment refractory colon cancer, we saw improvement clinically. Patients' pain went down, performance status went up relatively rapidly. What we didn't expect was that at week 1 and week 2, we'd see a CEA response that was quite dramatic almost immediately. And that was a sustained CEA response. In the patients with MSS, or mismatch repair proficient disease, we saw an elevation in the biochemical biomarker, CEA in this case, almost immediately as well, in quick progression. When we looked at objective response rate in the MMR proficient tumors or patients, we saw no responses, but we did see stable disease in about 16% of patients. In the mismatch repair deficient tumors, we saw a response rate of about 62% and a remarkable disease control rate over 90%. And in patients with non-colorectal cancer mismatch repair deficiency, we saw a response rate of about 60% and a disease control rate of 70%. Now that we've fully accrued these groups, I can tell you that these numbers have improved a bit, and hopefully will continue to accrue in expansion cohorts because of the results. In terms of the waterfall plot for responses, on the right in green and black are the responses in patients who have mismatch repair deficiency. In the red are the patients who have mismatch repair proficient tumors. One thing I think that's interesting is that we have a number of patients with mismatch repair deficiency, a handful that didn't respond. And it's not like they had stable disease and then progressed. They acted just like the mismatch repair proficient tumors. And when we sequenced these tumors, we thought, well, just maybe they were misclassified. They're false positive mismatch repair tumors. But these tumors also had thousands of mutations. So there's probably something in these cells that causes primary resistance. And I would think of it the same way that we think about KRAS with EGFR blockade. There's probably an alteration in those tumors that will prevent them from responding to immune stimulation therapy. And I think as we evaluate those patients are very important because not only will they teach us why patients don't respond in this situation, they may teach us why they don't respond in things like melanoma or lung cancer or kidney cancer as well. Here's an example of a patient with colon cancer with a large metastases actually surrounding the pancreas, and the patient responded beautifully. The patient's pain went away quite quickly, actually after a couple of weeks. And here are the Kaplan-Meier curves of progression-free survival. Again, in the red are the mismatch repair proficient tumors, in the green are the mismatch repair deficient tumors, and all cohorts are on the left, and in the black are the mismatch repair deficient other colorectal cancer groups. And on the right, you can see the mismatch repair deficient versus the proficient group. In terms of overall survival, again in the green, the deficient group, and in the red, the proficient group. In terms of adverse events, we saw accumulation of events that were related to autoimmune syndromes in the thyroid, the GI tract, the lung, and even the liver. With steroids and withdrawal of the drug, virtually all of these resolved. Looking at the histopathology of these tumors, in the top row are the mismatch repair deficient tumors, and you can see PD-L1 expression, the ligand for PD-1, is evident in the margin or the invasive margin. So where the tumor and the stroma meet, you have an accumulation of immune cells. And these are predominantly CD8 cells, and you can see when you focus in on the right, the CD8 cell staining there, and that's from the invasive margin. In the proficient colorectal cancers, you see largely an absence of this lymphocyte infiltrate. And so you see a low amount of PD-L1 at the margin, a low amount of CD8 cells. And when you look at, and this is endometrial cancer at the bottom, mismatch repair deficient endometrial tumor, you again see that infiltration of PD-L1 positive cells that appear all to be CD8 cells. Now we took a subset of these tumors and performed large-scale sequencing. We did the 20,000 gene exome sequencing on all these tumors, virtually, where we had tumor tissue, and what we found was the average number of mutations in the mismatch repair deficient tumors was about 1,700, and the mismatch repair proficient tumors was about 70. So a huge difference between the two groups in the number of mutations. And then when we stratified by number of mutations and responses, complete response or objective response versus stable disease versus progressive disease, there was a nice correlation between these. So in summary, mismatch repair deficient tumors, both of colon cancer and non-colon cancer origin, appear to be highly responsive to PD-1 blockade. Clinical benefit, and now we've seen a variety of different tumor types, is not just isolated to colon cancer, but we've seen in bile duct cancer, small bowel cancer, prostate, pancreatic cancer, endometrial cancers, and we're currently treating some pancreatic neuroendocrine tumors that are mismatch repair deficient, and a breast cancer that's mismatch repair deficient. So we think that this is a theme that's widely generalizable beyond just colon cancer. The biochemical responses correlated with objective responses, progression-free survival, and overall survival. That's something that had not been seen previously. In melanoma and lung cancer, sometimes the responses were delayed. And in our case, sometimes the responses were delayed. But the biomarker, which hadn't been looked at before, soluble biomarker, was able to determine very early in the first month of therapy, and oftentimes after the first dose of therapy, whether or not there was going to be a response or progression in that individual patient. And these tumors are highly enriched, the mismatch repair deficient ones, in a CD8 infiltrate, positive infiltrate, that expresses the PD-L1 ligand. There is currently a study that will open this fall that is looking at this in the treatment refractory colorectal cancer population called Keynote 164, and this is being sponsored by Merck. And in concluding on this part of the talk, so this was the first study that used immunotherapy to guide, or genetics to guide immunotherapy. Previously, it was almost like we treated with chemotherapy in the past. You take a tumor type and just treat non-specifically. Here, we use the patient's genetics to dictate who or who may not benefit from this therapy. The other thing that I think is a very important point is that this is going to help patients beyond just colon cancer, and our thinking is it may actually help approximately 3% of all cancer patients, because we think mismatch repair is represented across many different tumor types. Mismatch repair deficiency is easily detected and determined, as you heard earlier today, by both IHC and PCR-based tests. But the one question that we have going forward is, are we going to need different types of tests to look beyond just mismatch repair deficiency? Recently, POL-E and POL-D germline mutations have been described as a hereditary basis for some colon cancers. Those tumors as well have thousands of mutations, even above and beyond mismatch repair deficiency. The question is, will those patients respond just as well? And will looking at just mismatch repair be sufficient, or should we look at more sophisticated next-generation sequencing, maybe even of the whole exome? And this study suggests that genomics may be more influential than histology or even tissue of origin in dictating response or selection of a therapy for these patients. So, summary for the whole talk: somatic mutations can be effective biomarkers or therapeutic targets because of specificity. I think that's a concept that has been around for many years, but it's quite evident with circulating tumor DNA and targeted therapy that is its clear benefit. Somatic mutations can be used for alternative applications, not just for prognosis or as therapeutic targets, but as immunogens and as biomarkers, as I showed with the circulating tumor DNA. I think future therapeutics have to be creative. We can't just have molecules that inhibit certain pathways. We have to look at molecules that exploit how do we target tumor suppressors. So pathways that are, instead of being turned on, or turned off, but still can be used by the tumor to selectively grow over time. And future applications have to be used to look at unmet need. We've seen too many of these technologies enter the space with a lot of excitement, and rather than targeting the unmet need, they target the technology and they just don't meet the threshold for clinical benefit. I want to thank a lot of our colleagues and collaborators and our sponsors. Swim Across America is a group in the United States that sponsors a lot of cancer research, and they sponsored a lot of the studies. And the Ludwig Center of Cancer Genetics at Hopkins. I want to thank everyone for their time, and happy to take any questions if we have time.